Chapter 24, Intracorpuscular or Intrinsic Defects Leading to Increased Erythrocyte Destruction. Over the last couple weeks, we did take some time and look at the different shapes and names of the red cells. Now we're going to take those shapes and tie them to the diseases and learn a little bit about them. I had you write down a few diseases where you may find those just to kind of get a head start on it. But now things are going to kind of start coming together and as we dive a little bit deeper into those shapes. So I think that having that review earlier will certainly help you as we move forward. So we've got a couple major disorders when we talk about the hereditary defects of RBC membranes. The two major disorders are hereditary spherocytosis and hereditary elliptocytosis. Another one that we'll talk about is hereditary pyropoikilocytosis. Don't get too caught up in some of these names. I know they're kind of long and difficult, but kind of break it up into different parts. So I say pyropoikilocytosis, and then it doesn't seem quite so overwhelming, right? All right, so let's look at the first one. The first one is hereditary spherocytosis. This is a hemolytic anemia characterized by microspherocytes. So they're really small, dense, and they do not have a large central area of pallor, okay? This is the most common inherited anemia found in the people of the North European ancestry. The spleen is usually the cause of this type of anemia because the spherocytes found in the hereditary spherocytosis are very rigid and not as deformable as a normal biconcave disc would be. Normally, those biconcave discs can bend and flex, which is part of the reason why they are the shape that they are. They kind of look like a donut. Well, with these cells, the spleen will selectively sequester these abnormal red cells as they move through the spleen. This is where they become further damaged and are selectively removed by the macrophages in the red pulp of the spleen. With this, we see increased fragility of the cells, so they hemolyze very easily, and reticulocytosis as the bone marrow tries to make up for this. So with this, the primary defect is in the membrane skeletal proteins. If you remember way back to basic hematology, we looked at the skeleton and the different layers within the red cell. So this is especially in the proteins that connect the membrane skeleton to the lipid bilayer, or the outside layer of the cell. Red cells that have defects in proteins which disrupt the vertical interactions between the transmembrane proteins and the underlying protein cytoskeleton is where we see that issue. So this includes that spectrin, ankyrin, and then there's two proteins, 4.2 and band 3. Don't get too caught up in those. Just know that it is a skeletal defect, okay? So the membrane skeletal protein abnormalities cause the RBCs to progressively lose unsupported lipid membrane, which will again cause them to be very small and dense. Small portions of the membrane actually peel off without much loss of volume, and this acquires a decreased surface to volume ratio and a spheroid shape. Cells are very rigid and not as deformable, and survival in the spleen becomes decreased. We have three clinical manifestations with this. The patient will have anemia. They will have jaundice from the excessive breakdown of the cells, because we saw with the unconjugated to the conjugated bilirubin, that process happening will usually cause the patient to have excess bilirubin as well. And the splenomegaly from having them being sequestered in the spleen. So with this, we see spherocytes, which usually have an elevated MCHC because they're very small and dense. And if you look at this picture over here on the right, here's some examples of those spherocytes. Okay, they're small and very dense. We'll have a positive osmotic fragility test, okay, which we're going to talk about on the next slide. They will have reticulocytosis because the bone marrow is really going to try. Erythroid hyperplasia from having the increased speed of making up for all those red cells that are being lost. And decreased haptoglobin levels because the body is using all the haptoglobin to grab up all the free hemoglobin from them being lysed. All right, so what is the osmotic fragility? With this, the RBCs are placed in a hypotonic solution. It's usually a hypotonic saline solution. So think of saline with a little bit of water added to it. When this happens, water enters the cells until equilibrium is established. As this occurs, the cell walls usually swell and the internal volume causes them to burst. Now what you're seeing on the right-hand side here would be for a hypertonic solution, so they actually start to kind of decrease in size, but if we were to put it in a hypotonic solution, they would increase in size and actually explode. Since the spherocytes already have a decreased surface to volume ratio, they burst in a less hypotonic solution than normal RBCs. So if we have a slightly hypotonic solution, a normal RBC should survive. If we have a spherocyte, they're not going to make it real far. Okay, so we try different levels of saline solutions to add those cells to. Somebody with the spherocytosis will have a increased osmotic fragility. This can increase the difference between normal and abnormal result. Or you can increase the difference between a normal and abnormal by incubating at 37 degrees for 24 hours as well. We have some special tests that we can do. One of them is autohemolysis. This is very sensitive to hereditary spherocytosis, but it's not routinely used and it's very time consuming. With this one, normal RBCs are incubated and hemolysis just gradually takes place on its own. Adding it to those hypotonic solutions would actually speed up the process. So in the hereditary spherocytosis, due to loss of membrane and ability to maintain the cation gradient, hemolysis would be greater than a normal sample. So are spherocytes from immune hemolysis or are they hereditary? Well, the immune hemolytic anemias with spherocytes are differentiated from hereditary spherocytosis by the presence of a direct antiglobulin test. When this test is positive, it demonstrates the presence of an antibody to the red cell membrane. That would be immune. If there's an antibody present destroying the cells, that's immune. If it's hereditary, it means that there's a defect in that cell membrane. Okay. What is the treatment for this? Splenectomy. Okay. It prevents significant hemolysis. Can we fix the fact that the red cells membranes are not normal? No. But we can remove the spleen to stop the massive amounts of hemolysis that are happening because the cells essentially can still carry some oxygen. They're just more fragile, but we don't want them all being hemolyzed because that's dangerous in and of itself. All right, the next one, hereditary elliptocytosis. So here we have a defect in the RBC membrane skeletal proteins, similar to what we had with the spherocytosis, but with this one, the abnormality is either an alpha or beta spectrum. The effect of the RBC's deformability and failure of the RBCs to return to their normal shape after being deformed by shear force in circulation. So they kind of just take on this elliptical shape because of those abnormalities. So we see under the peripheral smear, we'll see elliptocytosis. As you can see, we did call these ovalocytes, but they're more cigar-shaped than like a macro-ovalocyte that we see in the megaloblastic anemias. So they look very thin and slender, okay? With this one, we will see the splenomegaly. The patient will have an increased spleen because it's going to sequester those because they look different to the spleen. That will cause the hemolysis. Again, splenectomy would be the treatment for that. The next one is hereditary pyropoikilocytosis. It's so fun to say. You guys got to start saying this stuff around your friends. It makes you sound super smart. This one is seen in infancy or in early childhood. There's severe hemolytic anemia with extreme poikilocytosis. If you look at the peripheral smear, it's kind of creepy looking, right? We see elliptocytes, RBC fragments, budding RBCs, spherocytes, and a very, very low MCV. In this case, most of the patients are usually of Black descent, and they have facial bone abnormalities, gallbladder disease, growth retardation. So there's a lot of additional issues rather than just having hemolysis taking place in the body. So treatment for this one as well, splenectomy, because we want to stop the spleen from sequestering these cells because that's more dangerous than keeping the cells themselves. Another one is going to be stomatocytosis, but what that refers to, and we'll get to that in the next slide, is having an RBC hydration issue. So RBC hydration is determined by the intracellular concentration of sodium and potassium. We have sodium and potassium pumps in the surface of the membrane to make sure that everything is osmotically sound, right? You don't want too much water rushing in, too much water rushing out, etc. If the cation content is increased, water will enter the cell and form a stomatocyte. If the cation content is decreased, water will leave the cell and produce a xerocyte. Okay? So here's some pictures. So with the hereditary stomatocytosis, which is also can be called hydrocytosis, there is the failure of the sodium-potassium pumps. Influx of the sodium and loss of potassium causes the cells to swell and become less dense and form this, this little slit-like thing that we see in the stomatocyte. We find hemolysis, we see stomatocytosis, we'll see some macrocytosis, and they also have an increased osmotic fragility, just like the spherocytosis cells do. The next one is hereditary xerocytosis. This is where cells lose potassium due to an RBC permeability defect. We see around 10% stomatocytes, we see target cells and Burr cells as well. With this one, elevated MCHC, decreased osmotic fragility, and hemolysis. So the difference with that one is the loss of potassium. The next one, acanthocytosis. These cells are really unfortunate if you look at the shapes of these over here. With this one, there's normal membrane protein composition, but the membrane lipids are abnormal. We have an increase in the membrane sphingomyelin and a decrease in phosphatidylcholine. This causes a shape defect that is not present in developing RBCs, but progresses as the RBC ages. So the cells that are being released from the bone marrow essentially look normal, but as they get older, we see these shapes start to take place. We'll see acanthocytosis in 50 to 100% of the RBCs. Okay, so it's very prevalent. They'll definitely have a hemolytic anemia because, as you can imagine, the spleen is not going to like these. It's associated with severe liver disease, A-beta proteinemia, anorexia, and hypothyroidism. So again, these diseases would have to be very severe before we would see this. The next one is an RBC enzymopathy. The first one is G6PD, or glucose 6-phosphate dehydrogenase deficiency. So with this one, let's go back to in most cases. So in most cases, G6PD reduces NADP while oxidizing glucose 6-phosphate. This governs the rate of reduction of NADP, which restores reduced glutathione and the hexose monophosphate shunt, going way back to either biochem or biology class, right? So G6PD provides the only means of generating the reduced form of NADPH, and if absent, the RBC is particularly vulnerable to oxidative damage. Okay, so you need it to prevent oxidative damage. In this case, there's a deficiency, so they're subject to oxidative damage. That is what you need to know. You don't need to memorize this first two sentences here. Okay? Usually African American male subjects are the ethnic group that we see with this. 10 to 11% of them carry the gene, and the gene is X-linked, so that female subjects are usually carriers and do not have clinical problems. It usually ends up being a male issue. In this one, we see Heinz bodies. These are produced after RBCs with G6PD deficiency are exposed to any type of oxidative agent. We'll also see reticulocytosis as the bone marrow is trying like crazy to try and produce more red cells. Haptoglobin is going to become decreased because of the increased destruction. We see unconjugated bilirubin increased because they're being destroyed so quickly. And hemoglobinuria, so some of that hemoglobin is going to be overwhelmed. As the haptoglobin is completely depleted, we will start seeing hemoglobinuria in the urine. The next enzymopathy is pyruvate kinase deficiency. With this one, pyruvate kinase is the rate-limiting key enzyme in the glycolytic pathway. It catalyzes the conversion of phosphoenol pyruvate to pyruvate with regeneration of ATP. Don't memorize that. It's just a little review. Some of the common triggers for this would be, this one is actually G6PD right here. So G6PD is drug exposure, mothballs, herbal supplements, and fava beans. So that's a G6PD one. I gotta fix this slide for you. The pyruvate kinase deficiency is a pyruvate kinase deficiency enzyme. Okay, and when this happens, it changes the shape of the red cells. We see polychromasia in echinocytes, which is like a Burr cell, or a crenated RBC. Paroxysmal nocturnal hemoglobinuria is the next one. With this one, there's intravascular hemolysis resulting from an RBC membrane defect that increases its susceptibility to complement. One hemolytic anemia caused by an acquired, it's the only anemia caused by an acquired abnormality. It can be mild to severe, and usually the hemoglobinuria arises from sleeping. Okay? This hemoglobinemia is sleep-induced and occurs only, obviously when they're sleeping. So they believe that the cause of this is due to having a lowered blood pH facilitating complement to bind to PNH cells. Exactly what that connection is between the pH and sleep, I'm not 100% sure on that, but we do know it is something that occurs at night, hence the nocturnal. With lab findings, we have pancytopenia, normochromic normocytic anemia, reticulocytosis, hemosideриnuria, which is of extreme diagnostic importance. We do a Prussian blue stain of the urine, which this will show blue staining hemosiderin granules in the renal tubular epithelial cells. Okay, so that would be very diagnostic of this. So that's very important. Hemosiderin is present and a useful diagnostic tool in paroxysmal nocturnal hemoglobinemia. Levels of CD55 are decreased in PNH, and hemolysis occurs when the blood is acidic and platelets and white cells are usually decreased. So they're pancytopenic as well. We do see hemoglobinuria and hemoglobinemia. The screening test for this is either that urine hemosiderin determination using the Prussian blue or the sugar water test, which we call the sucrose hemolysis test. If the sugar water test is positive, the Heme test, which is an acidified serum lysis test, is used to confirm. Okay, so we would take the red cells, subject them to sugar water. If that doesn't work, we move on to what's called the Heme test. So you don't have to know the details of those tests, just know sugar water and Heme go with paroxysmal nocturnal hemoglobinuria. And that concludes chapter 24.